The Pod of Inquiry, pushing the envelope for human understanding and optimization. The podcast for podiatrists. The Pod of Inquiry is designed to empower you with knowledge. What happens from there is up to you. Your host, Dr. Stephen Barrett, has designed this show to take you down some very deep rabbit holes, hopefully bringing you back out again, relatively unscathed, but cerebrally whipped, enabling a better understanding of all things worthy of inquiry. If you have more questions after the show, then that is good. The new discovery today many times was the new discovery 50 years ago, only to be suppressed or plainly ignored. Medicine and surgery can sometimes take a long while to get their paradigm shifted. We hope to have a lot of fun on this show and maybe destroy some ridiculous dogma along the journey. Thanks for joining the show today. Let's start spelunking.
It's really a pleasure for me to introduce my guest for today's show, Dr. Eduard Rabat. Dr. Rabat is an orthopedic traumatologist who has specialized in foot and ankle surgery. He did a long internship with Antonio Villadat, who is considered the father of foot and ankle surgery in Europe, or at least one of them. Dr. Rabat is the director of the foot and ankle surgery unit at Hospital Quirón in Barcelona, Spain. He is also a member of the different scientific committees of the European Foot and Ankle Society and is more than just a surgeon. I would have to consider him an artisan. When I first went to Spain in 2005 to instruct in some endoscopic procedures, I was fortunate enough to actually spend some time in surgery seeing the different types of percutaneous or minimally invasive surgeries that Dr. Rabat and his colleagues were doing, and needless to say, I was completely blown away by their skill, and they were just true craftsmen. It's hard to describe it until you see it, but for him to come on and share his experience with Morton's entrapment, or as he refers to it as Morton syndrome, I think you'll enjoy the conversation and get many things out of it, and hopefully it will empower you in the treatment of forefoot conditions. Please enjoy my conversation with Dr. Eduard Rabat. I'm here with my friend and colleague, Dr. Eduard Rabat. Dr. Rabat is an orthopedic traumatologist who specializes in foot and ankle surgery and has an incredible lineage in Spain, and I've been very blessed to have had the opportunity to work with him, and first met him actually back in 2005. And Eduard, thank you for taking the time to join the show today. It's such a pleasure to see you and revisit.
It's my pleasure and my honor, because it's the opposite. I learn a lot from you. It was great to meet you. That changed a lot of things in my life.
Well, that's very kind. We're going to talk about the forefoot today and Morton's. I hate to use the word Morton's neuroma. Hopefully that's the last time I'll say the neuroma word and call it Morton's entrapment. But you've done a lot of great stuff with the forefoot with your percutaneous or minimally invasive surgery, and wanted to dive into not only your classification system, which I thought was really well done, and we'll just talk about whatever comes up as far as how to improve forefoot surgery and dealing with Morton's entrapment and metatarsalgia. So I guess with that, let's go ahead and get started.
My topic is about the minimally invasive treatment of Morton syndrome, which is metatarsalgia, in fact. And it is neither from Morton, and also it is not a neuroma, because the first description of this condition was in 1835 by this man, Filippo Civinini, in Italy. But the first paper about that was, as everybody knows, from Morton. And I also want to share a classification proposal in order to choose the most efficacious treatment, the more efficacious minimal invasive treatment. Which are the techniques, the minimal invasive techniques that we use in the Morton syndrome? The endoscopic section of the deep intermetatarsal ligament. This is the the Stephen Barrett technique, the technique that we learned in 2005. But also we can use the DMMO, distal minimally invasive metatarsal osteotomies. Maybe it's interesting to show how we do these osteotomies through a little incision in the epiphyso-metaphyseal junction of the head of the metatarsal bone under fluoroscope view. You see that this is a Shannon bar, 12 millimeters, and the most important thing of this technique is that we start parallel to the long axis of the metatarsal bone, and we finish, the hand of the surgeon makes a supination, and we finish parallel to the metatarsophalangeal joint. This is a very important detail. Nowadays, in Europe, this osteotomy is, I don't know if it is in the first in the first position of the metatarsal osteotomies. I know that also in the States it's very in fashion nowadays, but it's very important to do the technique appropriately. Mm-hmm. As we can see, we finish parallel to the metatarsophalangeal joint. As an introduction, to tell you that we believe that the Morton syndrome has multiple clinical presentation with the same histopathological findings. And why a classification? The classification is to choose the most efficacious MIS surgical technique. For me, it helps in making the decision to perform an isolated transection of the ligament or to add other surgical techniques as the DMMO osteotomies. And then let me show you this classification proposal, which is a cocktail of if it is the second or third space, if it is a double or single space, and the most important, if the presentation is very mechanical or very neuropathic. Let me show you. Then you see, for me, it's very important to know if the Morton syndrome is very neuropathic or it is in the middle of a mechanical problems in the forefoot. Then we classified in 6 types. The first is the third space with a toe cramp. This is the maximal neuropathic presentation. The second type is a third space pain in the interspace without toe cramp. The third type is this is maybe the most polemical presentation. It's the second space neurological. That means without any other mechanical problem, any bursitis, any subluxation, only neuropathic symptoms. The type 5 is a double space, but only neurological presentation. The fourth type is a second or third space with a very biomechanical alterations of the forefoot. And the type 6 is a double space mechanical. Let me explain a little each type. Type 1 or 2 is the third interspace with cramp or without, is the classic Morton, the classical Morton. The type 3 in the second interspace is the most dangerous, as we will see after, because we need that the symptoms has to be only neuropathical symptoms with cramp or without cramp, but with any mechanical alteration in the forefoot. Type 5 is a double neuroma. Type 3 in the second space, type 1 or 2 in the third interspace. Type 4, this is very understandable because here you can see this forefoot with very long second and third metatarsal bones with a hammer toe, supraductus second toe, and look at in the MRI we can see this enormous inflammation, this bursitis. In the middle of all of this, there is a poor nerve which is compressed because of this mechanical environment. Normally, this patient has metatarsal pain, but most of them, they explain that has a cramp in the toe and has also neuropathic symptoms. Then this is the type 4. And type 6 is the other mechanical type. And here we found second and third space. The second is type 4, and is a mechanical full alteration of the two interspace. And then, again, why the classification? To choose the most efficacious MIS surgical technique. We will do isolated endoscopic section of the distal intermetatarsal ligament, the Barrett technique, in type 1, 2, 3, and 5. That means in the neuropathic presentations. And we will add osteotomies in type 4 and 6. Then we do the isolated and the endoscopic section plus the osteotomies, but also maybe we have to fix an hallux valgus or to fix a hammer toe. And then some years ago, with the help of Olivier Lafenetre, a colleague from Bordeaux, France, we make a study, a B-center study of 48 cases. 25 patients were from Barcelona and 22 patients were from Bordeaux, 42 females and 5 males. The average age was 56 years, and 21 cases had associated forefoot pathology. That it could be a hammer toe, for instance. The average follow-up was 22 months. And here, the results, we can see that there was 32 third interspace, 20 second interspace. That means double were 10%, third space 63%, and second space isolated 34.6%. And the classification, in the top was the type 2, was 42.55%. Then the fourth type, the mechanical one, 19%, and then the other. The type 1, the more neuropathic case, was 14.80%. The Morton syndrome diagnosis criteria was, first of all, the anamnesis and clinical exam, and then the complementary test in that order. The ultrasound was performed in the 100% of the cases, and in 7 cases, 14%, we did also an MRI for different reasons. Always a weight-bearing X-ray of the forefoot. For the evaluation, we used the Kitaoka scale, the AOFAS, very good, more than 90, good, 75, in between 75 and 90, fair, 60, in between 60 and 75, and bad, low than 60. The surgical technique indication, as I explained you, the endoscopic isolated in type 1, 2, 3, and 5, and adding osteotomies or other forefoot procedures in type 4 and 6. And the global results, we found that the patients considered themselves as cured were 85.2%. And here we have to see that very good were 76%, good 10%, and bad result 12.76%. If we study this by space, by space, the second space, the result was 90%, very good or good result, and bad result at 10%. And what happened in the third space? In the third space, very good result and good, 87.5%, and bad results in the third space, 12.5%. This is by classification. We can see that type 1, the good results were good or very good, were 100% of good and very good results. Type 2, we found 20% of bad results. This is the third space without toe cramp. Type 3, that is the more dangerous type, the second space non-mechanical, the bad results were 33.34%.
Edward, can I interrupt you for a second and let's go back to that because I want to ask you some questions on that. So just for the audience, the type 2 in your classification system is pain in the third interspace with no mechanical alterations in the forefoot. Is that
and
correct?
without cramp.
Without cramp. Help me with that. What because I think that's an interesting thing that you're putting into your classification system. Why without cramp versus with cramp?
Well, because there are the typical patient that explain you pain in the tip of the toe.
Mm-hmm.
As the only symptom, and sometimes they have consult some podologists because of the nail, maybe something in the nail, and this I compare like in the back, in the lumbar spine, like a sciatica, that the patient that has pain in the foot but without any other symptom. I consider this very neuropathic.
Okay. And so do you think that the people that present with cramping have more severe damage to the nerve?
Or more severe, or one thing is in which part of the nerve we have the thickening.
Mm-hmm.
Maybe
Okay.
because you know that there are some studies that show that sometimes the thickening is more in a branch,
Mm-hmm.
sometimes it's more in the middle.
Right.
And maybe it has something to do with this.
Okay. So just to go back then, the type 3, or excuse me, the type 2 and the type 3, the only difference between them is the cramp or no cramp.
No, in between the type 2 and type 3,
yes,
the difference is type 2 is third interspace without cramp.
Okay.
And the type 3 is the second interspace with cramp or without.
Okay. So that makes sense now because we saw in our study of 193 patients, we saw a lower success rate. I think it was 85% compared to 95% when you went from the second interspace to the third interspace.
Mm-hmm.
Okay. Okay. I'm sorry to interrupt, but I wanted to clarify that.
No, thanks. Thanks, because like this we clarify. No, and then we have studied also the difference in between the isolated ligament section and section plus osteotomies, no? Yeah. And the isolated ligament section, the Barrett technique, we found 83.22% of good and very good results, and 16.66% of bad results. That this is something that after I will explain, which is our opinion, why it happens, no? Okay. Then if we, the isolated, in this graphic, you can see the isolated section, how in type 2 is third interspace without cramp, we have maybe more or less, you see, 4 cases of bad result, which is a lot, but it's the type there are more cases also. Mm-hmm. And in type 3, second interspace, is where we found more bad results of the isolated section of the ligament, at 20% of bad results.
Do you want to tell us why?
No, excuse me, Steve. The type 2 has a 20% of bad results. Right. Third interspace without cramp. Okay. And type 3 has a 66% of bad results. Okay. This is with the isolated section of the ligament. Okay.
And the type 3 would be involving the second interspace, not the third.
Exactly. The second interspace.
Yes. Okay.
And then in the opposite side, when we do the section of the ligament plus the osteotomist, in between the good and very good results, it's 100%. Okay. probably is because the bad cases, the cases that involve the second interspace, they solve the situation very good with the osteotomies plus the endoscopic section of the ligament.
Understand. Now, this correlates with what we found in our study of 193 patients, and I think that we were only looking at ligament transection in that study. There was no mixture of distal metaphyseal osteotomies to my knowledge. But would you think that because there are more things going on with the second metatarsal phalangeal joint, with the fact that the first ray has its own mobility, so to speak, that the second ends up taking a lot more pressure, and that's why you have to really be aware of what's going on with the metatarsal phalangeal joint in addition to the interspace?
Yes, because I think that the reason why I think that we have to consider Morton syndrome as a metatarsalgia, not only a problem in the nerve. Sometimes the nerve is the only problem, but sometimes we need to do something else. In an index minus, for instance, there is also a mechanical problem in the second interspace.
Mm-hmm. I agree. And I think that would show why you need to add the osteotomy to the procedure.
Exactly.
Yes.
And then, sorry, excuse me.
No, I'm going to come back and I want to talk a little bit more about the mechanical or the biomechanical factors, but let's go ahead and I'll circle back to that when you're finished with the presentation. Before we continue with this great discussion, I just want to take a quick break to acknowledge this week's sponsor. This episode is sponsored by Savant Cellars, providers of boutique Tier 1 reds at a Tier 2 price point. Let's imagine you are spelunking in a cave out in Napa Valley, and you come across some of the juice from Savant Cellars. You may just never want to come out until it's gone. Savant Cellars sources all of their fruit from the really big-name boutique vineyards. That's right, where the elites get their fruit. If we put a vineyard designation on our bottles, we would be contractually forced to sell our wines at 3 to 4 times our current pricing. Yes, full disclosure, I am one of the 3 principals and I'm very proud of our wines. Savant Cellars is the genius of wine. Simply great wines, vintage after vintage, crafted in a Bordeaux style so you can lay them down for years or drink them now. They simply just get better. Use the code SPELUNK15 to get a 15% discount at savantcellars.com. That is CEVANT sellers.com. Spelunk15.
Okay, no, only to discussion that I believe, or we believe, that this syndrome should be treated differently according to the interspace, if it is the second or the third, and also with the neuropathic or mechanical characteristics. This is the reason why I use this classification. And also adding osteotomies in type 4 and 6, which are the mechanical types on our system, have improved dramatically the rate of good and very good results. In the second space, we have the best outcomes. In the opposite side, we have the worst outcomes in the second interspace with the ligament section.
Mm-hmm.
Okay. And then we believe that the addition on the DMMO osteotomy should be done only when there is a biomechanical disorder. That means that because there are some techniques that they systematically do the section of the ligament and also osteotomy. But we think that this is, we don't like that, because we think that we have to do osteotomies if there is a mechanical disorder, because we don't have to forget that an osteotomy takes more or less 3 months to heal perfectly well.
Yes.
On the opposite side, if we do endoscopic transections of the ligament in 15 days, the patient is come back to work.
Yes.
And then for that reason, it's very important to choose perfectly well the patient. And also, I think why the third and second space bad results, the bad results that we have found in this third and second space. maybe there is a bad technique, maybe a bad clinical evaluation in the second interspace in type 3. Maybe we consider without any mechanical disorder, but maybe the patient has a mechanical disorder and we didn't see it, no? And then we have a failure. And also a very damaged nerve, because we say always that the Morton is not a neuroma, but we have seen a correlation between the duration of the symptomatology and the results. It's something that we cannot prove, but we are in the way to prove. We think that a Morton, a nerve which has been affected during, for instance, 7 years, maybe this nerve has a true neuroma.
Well, and it certainly can have more trauma to it if it's been injected numerous times with steroids or alcohol. These types of things can be very injurious to the peripheral nerve.
Yes, this is the other reason, no? And then maybe you are treating a true neuroma, and for that reason, you don't have a good result, no? For instance, sometimes we see some patients that has suffered an injection of phenol injection or they has burned the nerve, and in these cases, I think it's unuseful to try to decompress the nerve, because now we have a true neuroma, and then we prefer to remove it.
Understood.
Okay. And we consider also that the effectiveness of Morton syndrome treatment lies in that we have to consider it as a metatarsalgia and to look at the forefoot as a whole. And this is my dog, which name is Morton.
So, Edward, that's a wonderful classification system. And I think the classification system that you've done is very important, because so many times practitioners will look at someone who comes in with Morton syndrome and they will just look at one little symptom or one little presentation, and there's no appreciation, for example, how much equinus. And do you want to comment on your clinical evaluation and how you factor equinus and whether you treat that or whether you don't concurrently? Or in our practice, if I see someone with very severe equinus, they have multiple interspaces, they have long second, third, and fourth metatarsals, they have, really a lot of callus formation. These are people that we'll do a gastroc recession on, and then I'll usually stage it, because about half the time in our experience, if we do the gastroc recession and offload that excessive pressure in the forefoot, a lot of those things will calm down. Tell me what you look at in your patients and in your practice.
Well, of course, we look always at the equinus, and we have some tests to send the patient to the physiotherapist to stretch. Mm-hmm. And when the patient improves the symptomatology after 1 month or 2 months of stretching, then we go for the lengthening of the gastro. Yeah. And nowadays, I don't know, in the States, this is something that we have talked with you in the past. Now it begins to be in fashion, the FHL, the flexor hallucis longus. Mm-hmm. You will see that now there are people who is arthroscopically open the gain of the flexor hallucis longus, and a lot of this symptomatology also disappear, because we have lived in the era of the gastrocnemius, and now I realize that it begins the era of the flexor hallucis longus. You see that when you push the foot in dorsally, mm-hmm. There, in many patients there is that you see that they bend the toes, no? Mm-hmm. This we consider that is the gastrocnemius, but it seems that if you release the flexor tendon, this also disappears, and the hallux limitus disappears. And maybe we will hear about that a lot, no?
Right. So what you're saying then, let me recap that. You're saying that if you have somebody with an overwhelming equinus, you always address that first before going out to the forefoot?
Yes,
Okay.
we try to
Okay.
do.
Yeah. And then let's talk a little bit about the metatarsal parabola, because I think this is one of the places where we are lagging behind you all over in Europe and Spain. I still see a lot of isolated metatarsal osteotomies when, for example, a patient may have a second metatarsal that is shortened with a while osteotomy or some other type of osteotomy, but they don't do anything to the third and the fourth. And they're very long too. You all taught me when I was over there that you pretty much need to take care of 2, 3, and 4 if they're all long, and not just do an isolated osteotomy on one. Am I correct in that now?
Yes, let me explain you how I manage this. No, I use very much the second and third rocker metatarsalgia. And the third rocker metatarsalgia is when there are long the metatarsal bones and the callosity is diffuse, no? It's not a only one callosity.
Right.
This is the propulsive metatarsalgia. The second rocker metatarsalgia is when you see this callosity in only one metatarsal bone, and normally the parabola is more or less normal, no? When in the third rocker metatarsalgia, we use the osteotomy second, third, and fourth. And if there is a quintus varus, maybe the fifth also.
Okay.
But with the having a lot of care with the cavus foot.
Yes.
Because with the cavus foot, we are always afraid. In some cases of important cavus foot with an important metatarsalgia and long metatarsal lesser toes, we do the DMMO, but we add elevation osteotomy of the first.
Okay.
That we do with a little incision and with a screw.
Okay.
Because a condition that is terrible is a transfer metatarsalgia from the lesser toes to the big toe. This is a condition difficult to treat. And then in the second rocker metatarsalgia, we do a proximal osteotomy. Because we do only an elevation osteotomy. That way we don't shorten the metatarsal bone, and we don't create a transfer metatarsalgia. No, this is in second rocker metatarsalgia when the parabola, when the second metatarsal bone, for instance, is not longer than the third or the fourth.
Yeah, no, I understand very well. Now let's talk about plantar plate a little bit, because there's a tremendous amount of plantar plate pathology, at least in our practice. And invariably, when I see a failed Morton's surgery, there's always a plantar plate and a long metatarsal involved. And when you shorten the metatarsal, are you doing anything to the plantar plate, or are you letting it heal? Because we've experienced that if you just shorten the metatarsal, the plantar plate heals.
We absolutely agree with that. And in our societies, maybe you know Ernesto Maceira, who has proven that when you shorten the metatarsal, you heal the plantar plate. And I have to confess that I have never repaired a plantar plate in a subluxated or luxated, in a rupture because of a second or a third very long metatarsal bone. We shorten the metatarsal bone, and that's all. I absolutely agree with you.
So I don't know if you've seen this work that we did. I published a small little case study a long time ago and I think it was after I came back and you had introduced me to Mariano de Prado, and I went down to Murcia to hang out with him a little bit. And I got back and I wanted to see what was going on with the plantar plate. And so I would use Omnipaque, and I would inject Omnipaque before we did the osteotomy. And if you put the Omnipaque in the metatarsal phalangeal joint and the plantar plate was ruptured, it would just leak out like a big blob of ink, of course, on the plantar aspect of the foot. You could see it very easily with a plain film X-ray. And then at 3 months, after the osteotomy, I would inject the omnipaque again, and now you would only see a little crescent moon because it held and contained the radio opaque marker inside the joint. And so that's how we kind of proved to ourselves that these plantar plates will heal you only need to shorten the metatarsal. And the problem with this right now is what we're seeing, and I only see the worst of the worst cases now, but I'll see people that have had tremendous amounts of damage to their forefoot, scar tissue, amputation, neuroma, because they've gone in and tried to repair this plantar plate. So can you comment on that a little bit?
I'm absolutely agree. We don't agree with all these plantar plate repair.
Right.
That you need an osteotomy, a screw, a scorpio, very complicated. And I know that this repair provides a lot of stiffness in that joint.
Yes. Yeah. No. I mean, that's the beauty about minimally invasive techniques is that there's less scar tissue associated with it. And when they open up the bottom of this metatarsal phalangeal joint to try to repair these plantar plates, one of two, there's a couple of things that happen. One is they always get excessive scar tissue. And sometimes they get more pain from the quote repair than they had before with just the plantar plate injury. So I've not been a big fan of those procedures at all. And I'm glad that you pointed out how the body can repair the plantar plate just by shortening the metatarsal, because I think that's a really important concept.
It's our experience too.
Yeah. So anything else you would add? I have one more question for you. So a lot of times when I have overwhelming metatarsal phalangeal joint pathology, long second, third, and fourth, I won't go and do the decompression of the inner space. I'll just do the while osteotomies, and I do them a little bit like you do, but not quite as minimally invasive. But by shortening those metatarsals back, it seems that we decompress that nerve somewhat by that. So I'm not trying to I guess what I'm saying is that by relocation of the metatarsal heads, it seems to bring that TIML proximal, and that seems to take some of the pressure off of the nerve.
Yes, I completely agree. And if you add the decompression, and then look, we have the best outcomes in our study are with this technique, no? Decompression plus osteotomy.
Yep. So would you agree that a lot of the failures or bad outcomes from treating Morton syndrome, and regardless of what technique, come from the fact that the whole presentation isn't being recognized by some clinicians, meaning that there is an overwhelming equinus that's being ignored, or there is a plantar plate rupture that's being ignored. And when you take care of just one part of the equation, it doesn't turn out very well.
Yes, absolutely agree. Absolutely agree.
So any other insight as far as Morton's and how you manage it before you take them to surgery? Because I think that's very, I think your system's very good.
See, because what I told you that an isolated transection of the ligament heals in 15 days.
Right.
You have to think a lot if you do something else, because you have to explain the patient that he will or she will have swelling and some disturbance on the forefoot during 3 months. No, then it's an important decision that you have to justify to the patient and to yourself. No, and this is my topic. What is about?
Yes. Well, and I think my philosophy has always been I try to do the absolute least invasive procedure to get the most outcome for patients. And I think that, that's why you have to really take and spend time with these patients clinically to try to figure out what's the best approach. Because I yet to find an algorithm that we can just plug everybody into. I mean, it's just, you have to look at them individually.
Exactly. Yeah. Exactly. There are no illness are sick people, no?
So then if you're let's talk a little bit about postoperative management, because I know a lot of people are going to want to talk about that. So with your percutaneous osteotomies, you're letting them weight bear immediately?
Yes, with a flat shoe, we encourage the patient to immediately weight bearing. Maybe the first or the first day more on the heel, but as soon as possible, full weight bearing.
Right. And then about 3
we
months?
We change the bandages. It's not the same if maybe we have done a bunion surgery also or hammer toes, then we have to manage the bandage. It depends on the patient. The special shoe is during 1 month.
Okay.
After 1 month, they start with something like a sneaker or something like that, and they begin a physiotherapy with ice, and they are able to walk. And normally in 2.5 months and 3 months, the swelling disappears, and then the patient goes very well. The only problem that you have to explain to the patient, and there is the swelling. The swelling of the forefoot is unavoidable. And then the patient has to accept, to adapt the shoe to the swelling. I always say that if the patient is not able to understand that, or they consider that their illness is not enough to do that, better not to operate the patient. No.
Right. Well, I think too that there's a lot of variability. I've seen some patients that have had, all of the osteotomies and the decompressions, and at 3 months they're ready to go fully back to their sport or full activity. And then I've seen other people that take a little bit longer, and they may take 5 or 6 months, but then, once you get that parabola corrected, the body heals and they do very well. So it takes some time. I mean, you're doing a big procedure in a highly, in an area that is subjected to weight bearing. So it takes some time.
Easy. Yes.
Yeah. All right. Well, I really appreciate you coming on and talking about Mortons and what you do in the forefoot. I have to figure out how to get over to one of my favorite places on the planet and hang out with you a little bit more, because I always have such a great time there. Anyhow, let's keep in touch, and we will talk about some other things that you're doing in the future.
That's perfect. It has been a big pleasure for me, and I'm very, very happy to participate.
Wonderful. Based on the very positive and inquisitive feedback that I've received from my conversation with Dr. Robert Kornfeld, which was Season 2, Episode 4, which we discussed the integration of functional medicine into your podiatric medical practice, I wanted to share with you my personal experience and why you should really think about taking Dr. Kornfeld's excellent functional medicine course. Over 20 years ago, I quickly learned that we had to treat the whole patient, not just the symptom down in their lower extremity. But I did not have the luxury of being able to obtain something like Dr. Kornfeld's training course. I had to piece it all together. And truthfully, I am still piecing it together, as it is a constant and evolutionary process that will never end, because new information is always becoming more and more available. But by taking his well-constructed course, you will have a strong foundation to continue that building upon. And maybe the best thing is that this will allow you to have the platform to launch out of the imprisonment of third-party insurance, which will improve your life. Think stress reduction here now, folks. And at the same time, you'll be able to optimize the lives of your patients. If you want to go from dysfunction to full function, start here right now. Functional medicine provides you with the powerful niche that will allow you to go into the direct pay model and be done with the insanity of participating with insurance. Go to his website now and tell him we sent you, because you don't want to be dysfunctional anymore. To get on board with this fantastic educational opportunity, go to Dr. Kornfeld's website, instituteforfunctionalpodiatricmedicine.com. That's instituteforfunctionalpodiatricmedicine.com.
We hope you all enjoyed today's show and got some truly empowering knowledge out of it. You can always follow up on anything we talked about in the show notes. found at our website, potofinquiry.com. If this incredible and educational conversation has tickled just a little bit of your cortex, please leave us a review and spread the message to your friends and colleagues. Let's keep spelunking.
This podcast is designed for informational purposes only and does not constitute any medical or surgical consulting advice or imply a development of any physician-patient relationship. The opinions of guests who are featured on the show are not necessarily the opinions of Dr. Barrett or the production team. This podcast is owned solely by Barrett Medical and Surgical Media, LLC. While the show is highly oriented for physicians and healthcare providers, anyone interested in the improvement of human performance and understanding will find this a welcome goblet to sip from, or guzzle. However, no representation or warranties are made in any way whatsoever on this podcast for any products, techniques, or other things discussed. Invited guests are not vetted by the Pod of Inquiry for their qualifications and may have a direct or indirect financial interest in what they present and discuss on the show. The Pod of Inquiry disclaims any responsibility from anything taken from the show and used personally or professionally. It is a responsibility of the listener to perform their own due diligence prior to the implementation of any ideas, products, techniques, or anything talked about on the show.